So our next speaker is Dr. Robert Ang, a very talented doctor who wears many hats. He has completed not one, but two subspecialty fellowships, one in glaucoma and one in cornea and refractive surgery. And he's currently the head of cornea and refractive surgery services at Asian Eye Institute. So he has an extensive experience with trabecular bypass devices and is one of the first Asia Pacific surgeons to implant the eye stents and the idols. So Dr. Ang will be advocating for trabecular bypass devices in the treatment of mild to moderate glaucoma. Robert, the stage is all yours.
Thank you, everybody. Thank you, Shelvin, and the All India Ophthalmic Society. And thank you, friends. Let me share my slides. So my side is to share with you trabecular bypass devices in the role in mild to moderate glaucoma. Here are my disclosures. I'm an investigator for Glaukos and Ivantis, which are manufacturers of mixed devices. So for me, mild to moderate glaucoma, what is it? For patients who don't have that much visual field damage yet, so not extensive or severe, historically, usually the IOP will run below 30 millimeters mercury. The IOP is controlled with 1 to 2 medications. These patients are not considering extensive glaucoma procedures such as trab and tubes, and it's okay to continue eye drops to maintain IOP in this group of patients. So in this survey, 77% of patients were considered mild to moderate. And in this other survey in the US, 1/4 of cataract surgeries have patients who are on a minimum of 1 glaucoma medication. So there is definitely a group of patients who might benefit from these devices. So for mild to moderate disease intervention, why trabecular bypass devices first? So for me, we want to restore and maintain the natural physiological outflow. The overall safety profile is very, very good. We want to maintain the natural pathway, and it is one of the most studied surgical interventions with multi-year outcomes data. I think at the start, all the companies have committed to providing as much meaningful and accurate data as possible. So on the left, he's the iStent inject, where there are 2 of these devices implanted. And on the right is the Hydrus microstent. So I consider this canal-based MIG. So I have experience with these 2 devices, and I will share them with you. So let's start with the iStents. The iStent started on the left with a snorkel-like device, and then it moved to the inject, which is the 2 rivet-like appearing stents, and then the inject W, which is a wider flange, so that we do not over-implant. There has been 20 years of experience with 800,000 eyes implanted and more than 200 peer-reviewed journals on the eye stents alone. So very extensive knowledge. And as you can see here, it's meant to bypass a diseased trabecular meshwork and maintain flow through the Schlemm's canal. So here are some of the outcomes in the pivotal trial. So all the trials of stents are phaco versus phaco with device. So in this study, iStent inject with phaco, you see that 75% of patients had a 20% reduction in unmedicated IOP and 31% reduction from baseline from pre-op to month 24. So very good outcomes in the pivotal trial. So as you can see here, they also studied if the starting IOP was less than 25 millimeters mercury, the mean decrease of the inject with phaco group was 6.2 millimeters. 25 to 30 pre-device IOP is 7.8, and if the patient is above 30 millimeters, 9.8. So the higher the pre-op IOP, the more reduction in IOP we deliver. So these are 5-year, 6-year, 7-year, and 8-year peer-reviewed journal outcomes of the eye stents. And as you can see, the behavior of the eye stents, even from my experience, is the mean IOP is around between 15 to 18 or 15 to 19, and it represents about 20 to 25% reduction in most patients, not all, but most patients. And the goal is reduction in medication, not to promise no medication, but reduction. So the glaucoma severity, so mild to moderate, both have good experience in reduction in IOP and mean medications. So the Hydrus is a larger stent. It has a trimodal mechanism of action. So it has a bypass. So it's like a straw wherein the fluid goes through. It dilates the Schlemm's canal and maintains it open, and it spans a longer range, 90 degrees or about 3 clock hours. And these are 5-year outcomes. 66% with the Hydrus are medication-free after washout. So here, 12 months to 16 months follow-up, and you can see that the eyes with the Hydrus have a mean IOP change of reduction of 8.3 millimeters mercury versus the phaco-only group. So phaco-only also reduces IOP. The devices give it an extra kick. This is one of the most important findings of the Hydrus pivotal trial 5-year follow-up, and it shows that eyes treated with the Hydrus are 2.8 times less likely to have glaucoma surgery after 5 years compared to those eyes with phaco alone. So this is one of the important findings in the study. So one thing that they studied as well is there an effect in endothelial cell loss? Because one of the devices that was recalled from the market had some endothelial cell loss, and the Hydrus year on year for 5 years shows a mean central endothelial cell loss of stable less than 10%. So here are some comparative studies of inject versus Hydrus, inject versus Cahook dual blade, inject versus Hydrus versus KDB. All the trabecular devices reduce IOP at different levels, but suffice it to say that these are follow-ups that are 6 months, 12 months, and 24 months. And real-world outcomes show that going trabecular bypass does work. So for my personal experience, I started implanting Hydrus and iStent 7 years ago, joining the clinical trials. One thing I can share is as you implant more stents, it doesn't matter if it's iStent, Hydrus, or inject, the surgery does get easier. Typical outcomes, so the doctor and the patient have to have realistic expectations, meaning don't promise no meds. We want to lower the IOP with or without meds, and there are maybe more than half of patients may be medication free, but not all. So from my experience, those on pre-op 1 med, post-op 60% of them end up unmedicated. Those that are on 2 meds, maybe only a fourth are unmedicated, half will still have a med, and the rest, same meds, 2 meds, but lower IOP. So the post-op unmedicated IOP of most of my patients is between 16 to 20, and the post-op medicated IOP, if you want lower IOPs, you can actually add medication. So one thing that I want to emphasize is canal-based MIGS, trabecular bypass devices are very safe because you don't destroy angle or iris. You don't cause hyphema, hypotony, endothelial cell loss. It's a less than 5 minute addition to phaco. If you place it in the wrong location, there's no harm to the other structures, and you do not have to remove it if you place it wrongly or if it doesn't work. It does not displace over time because we take photos of our patients 5 years out and they're still where we put them. Rare, but sometimes iris tissue can obstruct. So I have some patients who are narrow angle pre-op. I put them. Sometimes the angle zips and tends to cover one eye stent. No problem. You don't have to remove them. You just have to put them on some meds to help the pressure down. And it does not preclude other glaucoma procedures. So what if IOP control is not enough? Well, you can, if you use the inject, you can add another stent. So now we are doing studies on injecting 3 stents along the nasal hemisphere. And there is actually a study of combining stents with travoprost because prostaglandins work via UV scleral outflow and the mixed device, the traditional trabecular outflow. So there's a synergistic effect. And over time, these are the study results. As you can see, medicated IOP is 12 millimeters mercury over 60 months, 5 years. And unmedicated IOP after washout is about 16 to 17 millimeters. So if you want an additional effect, you can put a prostaglandin even if your eyes have a canal-based MIGS. So in summary, the trabecular micro bypass stents for mild to moderate glaucoma preserves the normal anatomy. It has a very high safety profile. I call it additional push in lowering the IOP. It is easily combined with phaco. And I tell the patients there's a chance to lessen or maybe eliminate medications, but no promises. And one thing that you keep in mind is you still have to learn this because if your conjunctival scarring procedures fail and you need to lower the IOP, putting them on a MIGS, canal-based MIGS may help your patients. So it can be reversed. You tried the more severe glaucoma, trabecular glaucoma surgery options, and then you go back to the MIGS to help you out. So as a final note, if my mild to moderate glaucoma patient on 1 to 2 medications is about to undergo cataract surgery, is it prudent or am I a responsible doctor to offer or perform canal-based MIGS? And most certainly, I think yes. It is my duty to tell them about the MIGS and let them decide if they want to or if they can afford to, but I have to make sure that they know that they have an option during cataract surgery to have a trabecular bypass device in their eye. Thank you very much.